Welcome to SheTV.com, where board-certified physicians talk to you about women's health. In this episode, Dr. Whitney Driver, a board-certified OB-GYN, talks to us about birth plans.
Well, hi, everybody. I'm Robin Bayless. I'm a board-certified anesthesiologist working at Lakeside Women's Hospital. I'm here with Dr. Whitney Driver. She is a board-certified OB-GYN. She and I have worked together many years at Lakeside.
Almost 13 now? Yeah.
It's been a while.
Uh-huh.
I've been there, shoot.
Don't do the math. It'll make you
25
sad. Don't do it.
25 years. So today, Dr. Driver wants to talk to us a little bit about birth plans and doulas. So tell us what you think about all that.
So I usually bring it up somewhere in the midpoint of pregnancy because having this discussion early in pregnancy isn't always helpful because things can change. And waiting too late in pregnancy isn't helpful because then I'm not allowing my patient the time to prepare for whatever their preferences are. So one of the first things I always say to patients when they talk about birth plans is I say, I prefer we use the word birth preferences because calling it a plan is much like saying I have a plan for motherhood, which you have 2 kids. There's no such thing as a plan. Like, it's how you hope things are going to go, but you have to go into it every day knowing it may not go exactly how I want, but in an ideal state, this is what I would like to see happen. My recommendation to patients is typically to first look at birth plans. If you Google, you'll get a bajillion options. And so I encourage patients to get one printed out, to look at it, and bring it to me as a discussion point. Many patients haven't pondered any of these things and just have basic questions about why would someone want to do this versus that. And that's my job. My job is to educate you and to explain what are the differences and what are the controversies surrounding that and what is my recommendation. About 75% of things that appear on birth plans online are standard of care that we all agree on. You don't need to ask for it. We all agree on skin to skin. We all agree on delayed cord clamping. We all agree on your support person or partner staying in the room with you and being with you. We all agree that you need to make your decisions about pain control when that time comes. Those things don't need to be written down and listed out. We're all on the same page. Many of the things are reasonable options. So at Lakeside, we offer what we call the unmedicated labor set. It's a standardized order set that for patients that are hoping to avoid pain medicine, that allows them to be more mobile, that allows them to be off of the monitor, that allows them to have clear liquid diets while they're up walking around, that allows them not to have things hooked up to them. And we all agree those are safe, reasonable options, and we want to provide patients the opportunity to labor as unassisted as they want, but as safely as they can. So patients are generally pretty pleased with that portion. And then I say there's about 10 to 15% of things that appear on these birth plans that are unreasonable requests that we can't have floating around on a chart. I've never had a patient in all of my years of having this discussion say, I would really like a giant episiotomy and forceps. That's my goal. I would really like to see things go that way. I don't need you to say, I refuse a C-section, I refuse an episiotomy, I don't want. Because in the event that I need to offer you those things in an emergency, having those sort of worded documents floating on the medical record puts me in a precarious position. Similarly, I don't want to have IV access is a complete non-starter. I had a really traumatic experience in my training years of a patient who was laboring without IV access, who ultimately required an emergency C-section. And there was nothing anyone could do until anesthesia was able to get an IV in her, which took about 7 minutes because she was dehydrated and been laboring. So having a little plastic flexible catheter, nothing hooked up to it, but there, if my anesthesiologist needs to give you life-saving medicine, is an important thing. And so, having that conversation of why I don't want those things on a birth plan generally goes pretty well. And then the last few things that appear on them are your genuine preferences, the things that are important to you outside of the norm that are unique to your circumstances. They're often things like, we don't know the gender and I want my husband to be the one to announce it. And I think that's great if those are the things that are important to you, but let me put it in my notes. Let me tell the nurses, hey, the patient would really like for her husband to announce the gender. And then your nurse looks at your prenatals before she admits you. She knows what your goals are. She can come in and introduce herself and be like, I hear we're having a surprise baby and you're the one that gets to announce it. And the whole dynamic shifts rather than you coming in with a list saying, I want you to do your job this way today. And it's just a much better dialogue for me and the patient to have in clinic.
Right. I think that's a really good perspective on it, because I've heard the nurses talking about birth plans out at the desk, and it usually starts with,
Right. And often if you look at them, they're really not unreasonable. So many of the things that are on there that patients are hoping for are things that, like I said, delayed cord clamping. We universally agree on that. It's a tracked statistic. The nurses are charting how long we're able to provide delayed cord clamping because we all agree there is benefit there. So that's not a request that you need to feel adversarial about. Oh, I need to advocate and make sure that happens. When I have patients that have questions about things related to infant care, that's another thing that appears on there. I encourage those patients to go find a pediatrician and go talk to the pediatrician. I'm not a pediatrician. I lean heavily on mine for all of the decisions taking care of my own children, and I rely on her expertise, and what she tells me I should do is what I do. And so if you're unsure about vaccines or vitamin K or the eye ointment, talk to the person that's going to be taking care of your baby. It doesn't have to be this opposing forces relationship. That's not what any of us went into medicine to do. We went into medicine because we care. We want good outcomes. We want to take care of you. And so I'm happy to have those conversations. I'm happy to show you both sides of the coin. I'm happy to explain to you where the middle ground is. And are you going to find my hardline boundaries at times? Yes. You're going to find the points of, I'm not willing to compromise on this. But those are few and far between. There's a lot of compromise to be had as long as everything's going well. You just have to respect that if it doesn't go well, that's actually what you need me for. When it's going great, I can be somewhat unnecessary in the process, and I'm okay with that.
all right, that's great. I'm sure that'll be really helpful. This is old doctor talk. Here. A couple of things this is an old joke first. How do you make God laugh?
Make a plan.
Make a plan, right? And that's what I think every time I see a birth plan, especially when there are so many different factors involved in labor and delivery that rarely, I would say something is from what I've observed is if you make a plan, don't attach it to your heart.
Right.
Make sure you understand that nature, God, or whatever may change your plan.
Right.
And change how things go. And if things don't go the way you go, don't be just crushed and disappointed about it. Just understand from the start that this is the plan. That may not be how it goes at all.
Which goes back to my comment about I don't like the use of the word plan. And that's what when I enter the conversation, I want to know what your preferences are. What is your ideal state? And that is a wide range for women. I've had women that don't want to do skin to skin. I've had patients that doesn't really appeal to me. I would actually really prefer that the baby be taken to the warmer. And I don't give her any pushback on that any more than I give the patient who wants 4 hours of uninterrupted skin to skin. Okay, great. Both of those are reasonable options. I just need to know what your preference is on that matter. I had a patient who really strongly, for personal reasons, wanted her husband to be the first person to hold the baby before she even held it. And so that's an easy thing to honor. Patients that want to bottle feed and not breastfeed, great. That is your preference. And so it's not that I'm trying to identify a particular patient population by asking that question. It's really trying to start navigating my care to where I can try to honor your preferences while maintaining my job of keeping you healthy and keeping your baby healthy and giving you recommendations based on my knowledge and experience. But I want to know what your preferences are so that I can take that into consideration with all the other inputs that I'm trying to take into consideration.
Makes total sense. I have one other piece of old doctor wisdom. What I found is this is something doctors do to other doctors when we're patients. We've always got some special request that we want the doctor to do that's not totally unreasonable, but not the way that doctor does it. So what I've seen happen over and over is you ask the doctor who's taking care of you to do something special, and it doesn't work out quite the way you wanted it to because it's not what they do. You're asking, so I have this little thing I do. Like, I walk the same path every day because I know over here there's a pack of wolves, and over here there's a cliff,
Right.
and I stay off of those. But if somebody drags me off onto their own path, I don't know where the wolves and the cliffs are.
Right.
And it can very easily not turn out as well as if they just let me do what I usually do.
I was the exact opposite as a patient, which I know is shocking since I'm a control freak in all things in my life. Like I bring Aries energy and Enneagram 8. We should do an Enneagram one of these at some point. But I bring Enneagram 8 energy everywhere I go, except when I was the patient. And I knew when I was having my baby at Lakeside, being delivered by my best friend, nobody in that building wanted anything bad to happen to me or my baby.
Right.
Everyone in that building wanted a very happy outcome for me and my baby. And they were like, do you want your monitor on? I said, no. I never looked at my own heart tracing. I never did anything. I laid there. When they told me to turn over, I turned over. When they said we were going to check you, I let them check me. And I just released that knowing that when I show up every day, I want the best outcome. So why should I expect anything less from the people that were taking care of me and my daughter that day?
You know, that's not how I was initially as a patient. As a young man, I had all these things that I thought needed to be done. But the older I've gotten, I remember the last time I had a tonsil surgery when I was 50. And it was one of my buddies that was taking care of me, and I just relaxed. I didn't have any special requests. He said, "This is what we're doing. This is how we do it." And I said, "Okay."
Right.
And it went great because I let him and the surgeon do everything exactly the way they normally do it, and I didn't interfere at all. And the older I've gotten,
I think it's different too when you have a level of expertise. I know nothing about how to give anesthesia. I know nothing about how to take out tonsils. So when my youngest had her tonsils taken out, again by a dear friend of mine, I had no feedback for her other than like, have a great day. You hope you slept well last night and you had a good cup of coffee and everything's going to go great. I do have expertise about obstetrics, but I respected that the people I chose to take care of me were gonna take care of me.
Right. That's the message I really wanted to get across is, sure, express your preferences, but don't get in the way of your physician taking care of you. The physician has a process that they go through every day, and a system and a way to avoid complications. And if you ask them to do too much that's weird to them, you're asking for complications.
Well, and especially in obstetrics, I wish I had one path I could walk every day, right? I have no idea where the wolves and the cliffs are in your metaphor. They're everywhere.
Right.
They're encircling me, and I'm in a constant state of hypervigilance, looking out and taking all these various inputs from two patients, typically, when I'm talking about obstetrics. And so I'm trying to take the input of what are your preferences as well, but my goal is always the same every day. And so like you said, when you start trying to add in more inputs and more variables and more restrictions, it does get more difficult. And I want to try to honor those things. It's just sometimes I have to reprioritize which input is the most critical in this moment.
Right. Well, I think that's very helpful. I had another subject I thought we might talk about just for a minute if you've got time.
Yeah.
Is what do you think about women employing doulas to help them with labor?
For patients that are desiring an unmedicated birth, I actually recommend it, and the data supports it. The data says,
really?
There's data from the OB-GYN world showing that doulas do actually speed up your labor and expedite time to vaginal delivery. The caution I give patients when they start talking to doulas and interviewing doulas, just like they make decisions about who's going to deliver their baby, is making sure you're working with a doula who is respectful and enthusiastic about your hospital birth. When you've made the wise decision that you want to have a baby in a hospital, to know that if some of the unknowns and if some of the bad things do happen, you want all the right people there with the skills to take care of you in that emergency. But your goal is, I would like to do it with as little intervention as possible. And if I don't need all those extra people, then great. I just want them available to me. That's the question you need to be asking your doula. And I have had some wonderful experiences with doulas in hospitals that don't see me as their adversary. They don't view their role as protecting their patient from me. They view their role as, how do I support this patient? Your labor nurse can't be a doula. And there are plenty of labor nurses that would be fabulous at that job. And that if modern healthcare allowed them the opportunity to do nothing but sit at your bedside and support you and help you make suggestions, and let's try this position and let's do that and let me provide counter pressure here, they would love to do that for you. But modern healthcare says they can't do that. Modern healthcare says they need to be sitting at the desk helping watch all the other strips, and they need to be charting on you every 30 minutes, and they need to have more than one patient. So your doula provides that. Your doula is the person that sits there and when you're getting frustrated, gives you that pep talk and pushes you through that and makes suggestions and uses her knowledge of, well, we could try this. And if you and your baby are both doing well, she's likely going to get you to the finish line faster. But if you encounter someone whose energy is more, well, have you thought about maybe not having a baby in the hospital? Or they present you with a birth plan like we talked about earlier that's very restrictive and harshly worded. That's a red flag. When you've decided your goal is to have a minimally intervened upon hospital-based birth, and their goal is maybe not hospital-based or no intervention, you're not lining up. But there are plenty of doulas out there that walk that middle ground beautifully, just like as a provider, I can walk that middle ground of not saying everybody needs full court press every intervention possible.
Right. What do you think about the doulas that try to talk women out of labor epidurals, though?
So that is, I don't know that many of them completely try to talk patients out of it. I think it becomes difficult when, as a doula, they recognize that their patient's intent was to have a child unmedicated. That why was how they came to seek out the doula initially, was I'm hoping to avoid an epidural. And so the doulas find themselves confronted with, do you really no longer desire that experience, or are you just so uncomfortable that you're getting frustrated and I need to help you manage that pain differently? And so I think oftentimes you get into that power structure of, is this somebody who's very anti-hospital-based birth to begin with, or are they just not supporting them in the right way? And it's not an often event where I see that that the doula is really trying to obstruct somebody. It does happen. And those are oftentimes patients that I don't feel like heard me on my advice about interviewing doulas. And sometimes they're not my patients. That's the other hard thing, is when I don't have a good relationship with the patient. If I'm on call or I'm a stranger to this person, that's always a harder dynamic.
Sure.
But sometimes there comes a point where I am suggesting an epidural as a way to improve labor and say, I think your issue is you are so uncomfortable and you're not tolerating and you're just tight. You're fighting it. You're resisting. Your muscles are tight. And if I can get you to relax and I can get those muscles to give a little bit, I think we can get there. I do get frustrated when people are like, well, that's not what she wants. And I'm like, well, but she also really wants a vaginal delivery. So we got to figure out how we're going to get to which goal is most important to her right now.
I have witnessed over the years of doing labor and delivery anesthesia that there's a certain amount of shame that gets applied to patients who change their minds about, they're like, okay, I thought I wanted to do this without an epidural, but now this really hurts. I don't want to keep doing this. And then there are people who will shame them for that. Not like out and out openly, but like if the woman had a mom who had 5 babies without an epidural, or I have seen doulas do it before too.
I've seen it more from family members. Shame of, well, I did it.
Right.
And I don't know that they mean it to be shameful. I think oftentimes they mean it, and you can do this. But it sends patients down a shame spiral. It's similar, though, when a patient ends up with a C-section, that they somehow shift their value and their worth as a mother and as a person into how they gave birth. And changing your frame of thinking. My frequent line, I'm sure you've heard me say it to patients, there's no way you haven't at this point, when patients get really upset about an unplanned cesarean, I always say, when you got that pregnancy test, you thought about a baby and you imagined holding a baby. And when you had your ultrasound and you found out it was a girl, you started thinking about dance recitals and soccer games and prom dresses. At no point did you think about your vagina. And at some point late in this process, you became very focused on that one part of motherhood. And that's not the goal. The goal has always been, I want to take home a healthy baby and I want to have this lifetime of stories and adventures. It is not about how your child is born. And shifting your priority from your worth and your experience being about that one moment is such an important mind frame to have. I could have cared less how my children were born. I was blessed with 2 great vaginal births, but I truly went into it being like, I just want to take home a baby. Right. However this happens is how it happens. And we didn't know with our second daughter if she was a boy or a girl. So all my enthusiasm in that moment was surrounding, who am I about to meet?
Right.
It had no value to me how I met that person. I just wanted them to be healthy and well and come home with me.
Awesome. Mm-hmm. That it circles back a little bit to making a plan again and your expectations. It's all about your expectations. Let your expectations be pretty lax when you go to having a baby is what I would say, because you might end up, even though you think you don't want an epidural, you might end up wanting an epidural because it hurts.
Right.
And even though you're planning this vaginal birth, you might end up with a C-section.
Right.
Don't let any of that ever shame you
or
make you feel bad about you as a person or a mother.
It's the perfect introduction to parenthood. I mean, I started off this day thinking I was going to run over here and have an interview with you, and we had to pause because my dog's vomiting and my kids are freaking out. And they're like, welcome to parenthood. That was not on my bingo card for today. Right. And that you just got to learn to roll with it.
That is true. Well, I guess it's time for you to go help clean up the
dog. Oh, really? No, I'd rather stay.
All right. Well, thank you, Dr. Driver, for joining us today.
Thank you.
This has been amazing. I hope we can drag you back in here because you are really good at this.
Thanks.
All right. Bye, everybody.
Bye.
Thank you for watching SheTV.com, where board-certified physicians talk to you about women's health.